Hello, my name is Anais Troncoso, and this is my signature assignment presentation for FNP 597 for a clinical soap note. My clinical site was situated at a family practice here in the Imperial Valley. It was with Dr. Alidad Sadeh and Jessica Ruiz, family nurse practitioner, as my preceptors. This case is regarding a 55-year-old female complaining of an increased in weight, rapid weight gain that has been that was not unexplained, and the reason why this case was meaningful to me and challenging was because it is pertinent to hypothyroidism. The reason it hits close to home is because in my family there are many people diagnosed with this disease, from my mother to my grandmother and a few other aunts. There's times it goes through my head that I'm probably going to end up getting diagnosed with it. And the reason is it's meaningful also is because it's sometimes an underrated diagnosis. Patients are just told at times that it's just change in hormones and it's gonna be fine, but it entails so much physiological and emotional changes too, that at times the patient does not know what to expect or they might be overwhelmed with. And that's why it's good to have that holistic approach with them when we discuss this type of diagnosis. We'll get more into the presentation of the case. Again, the patient is a 55-year-old married Hispanic female with the chief complaint. She has been gaining weight very quickly. She is a good historian who presents to the office with this complaint of this weight gain over the last 6 months without any changes in increase in appetite or daily caloric consumption. She also notes that she's becoming more intolerant to cold weather and has to wear a jacket even inside her office. She is attempting to control her weight gain by walking in the park every other day, but feels it's not helping much. In regards to her review of systems, the only remarkable thing is that the patient is positive for weight gain. Other than that, the whole review system is pretty unremarkable. Patient denies any changes in hair texture or anything of that sort, and that the patient also says that she does become fatigued some days. In regards to her past medical history, the only thing she has aside from is that she was previously diagnosed with hypertension in 2012. She has been in menopause since 2018. No allergies. She takes lisinopril for the 20 once daily for the high blood pressure. In regards to her family history, the patient, and she has had no hospitalizations. The patient's family history: the mother is a diabetic who is alive at age 82. She has two sons that are in their early 30s and both healthy with no past medical history. And she denies tobacco, illicit drug use, or drinking alcohol. Throughout doing a 24-hour food recall, the patient stated that she does have 3 meals a day, consistent of chicken, vegetables, and eggs. So she does have plenty of protein, and she snacks on celery, popcorn, carrots. She'll exercise for 30 to 40 minutes. When she does brisk walking or tries to run. She has about 2 cups of coffee a day and denies any workout supplements or any type of supplements. The patient's vital signs were normal. She has a height of 60 inches, a weight of 141 pounds, and she does present a BMI of 27.6. Her labs that were pertinent to this case, she presents a TSH of 5.5, free T4 of 0.4, a hemoglobin of 15.4, as well as a glucose of 78. In regards to her physical exam, everything was unremarkable. There was no goiter or the thyroid is still smooth without any nodules noted. So now getting down to our assessment portion. The differentials I considered, first of all, was hypothyroidism. my critical thinking process led me to this because of the complaints of fatigue, unexplained weight gain, as well as the elevated TSH and low T4 that was presented by the patient. The second differential I had was that of anemia related to unexplained weight gain and fatigue, but this was ruled out due to a normal glucose level. Anemia was our third differential, that we came to this conclusion related to fatigue and elevated TSH, but it was ruled out to normal hemoglobin levels. My final diagnosis was hypothyroidism. My critical thinking process again was based off on my the patient's clinical presentation, along with the lab work that was presented, and the guidance of my preceptor, and using evidence-based information and guidelines, as well as reading American nursing journals and journals on women's health. My plan was to put the patient, start the patient on pharmacological treatment with levothyroxine of 50 mics, 1 tab orally on an empty stomach in the morning, once daily, with the quantity of 90 and refills times 1. Then we went ahead and we're going to do a recheck of the TSH and T4 levels in 3 months to assess if the medication is working for the patient and helping to regularize her thyroid levels. We also suggested to monitor portion size and increase physical activity. The reason why I selected this therapy and pharmacological treatment was because the patient is at a point that she does need that increase in hormones to help with their hypothyroidism regulation, with their thyroid regulation. The support that I had for my plan was by that of my preceptor, and again using evidence-based guidelines through my texts and journal articles I have read. The alternatives that I considered were that of using interventions such as dietary changes and increasing activity levels. Now we're going to go into the holistic approach of this case. I collaborated with the patient's husband. Why? Because he is her partner in the home. He is who can help her stick to these dietary changes, lowering carbohydrates, trying to monitor her portion size, as well as increasing the activity level. The patient needs like an exercise buddy, and for the person who is her life partner to help her navigate through this disease process. Another, as well as her children, her daughter was came in with her, so we asked to just be supportive and plan out like diet ideas or different meal ideas whenever the family gets together. Something I think I could have done differently, or I could have added now that I reflect back on this case, was probably recommend a support group to the patient. Again, the reason is because these patients go through a lot of physiological and emotional changes, and if they know that there are people in their same disease process, they would feel comfortable speaking to them too. There's groups online, there things of that sort that the patient can confer to. The caring processes that I considered with this patient, one was to develop and sustain a helping, trusting, authentic caring relationship with the patient. This is important because we are their primary care providers. The patient will go through this disease process for a while, so she needs that support. It is going to be probably a lifelong, long-term disease management. Another one was to engage in genuine teaching learning experiences. Why? Because the patient has to be seen as a whole person. Their emotions, their behavioral changes, all of that, as well as the pharmacological addition that we're making, has to all work together. And just assisting with basic needs is another of the caring processes. Having the patient feel that caring touch by her provider is going to make her disease process smoother and help our job as a provider, help us as providers be better. Thank you.